Dr. Kim and I are going to kind of tag team this a little bit. Given her area of expertise, it made much more sense for her to talk about autoantibodies. And so the kind of the division of things, I think I put it there, yes. So the goals are, we're going to talk about basically the different kinds of testing that are relevant and different treatments. And I'm going to talk about most of the testing, but not the myositis-specific antibodies, and steroids, but not the rest of the drugs. And so we'll kind of exchange. It'll be obvious. It should be really informal, so if people want to interrupt and ask questions, that's great. If people want to save their questions till the end, that's fine too. I think between us, we're talking, I think I have about 20, 25 minutes. She has about 20, 25 minutes, which would leave us like 40 or 45 to just ask and talk about random stuff. But as I said, feel free to interrupt if you have something that's burning. So conflicts, as I said this morning, my only real conflict is that I'm the chair of the JDM committee with Kara, which does color some of the things that I might think or have to say. And just in the tradition of previous years, people remember, I think, in Florida, it was actually quite a bit worse than this. But if you actually look at that snowbank, you can just barely make out the roofs of the cars. And this is actually before the 8 more inches that fell as I was driving to the airport on Thursday. So you should all thank my wife for letting me come. So I'm going to start with these two distinguished looking gentlemen. You guys have heard about them, I'm sure, a bunch of times over the course of your experience with this, about these guys named Anthony Bohan and James Peter. And so these are the guys who basically wrote the paper that we essentially still reference as kind of the criteria for diagnosing JDM. Now, it turns out this paper wasn't about JDM, it was actually about dermatomyositis. They didn't really talk a whole lot about kids in their paper, other than to mention that, okay, this was another version of things. But it still it ends up being kind of a reasonable framework to kind of start with. Now, in their paper, they basically describe the criteria that you guys are probably mostly familiar with, that in order to diagnose dermatomyositis, you have to have symmetric proximal muscle weakness, and by proximal we mean closer to the middle of your body, so spine and neck, abdominal muscles being kind of the most central, and hip and shoulder girdle type stuff. They included muscle biopsy as a criterion, they included elevation of muscle enzymes as a criterion, they included EMG, and you can actually appreciate just looking at these things, that it's basically rash and a whole bunch of stuff that says that there's something wrong with your muscle. And actually, a lot of people have argued that you probably don't need to have all these criteria. But if you have a typical rash and any piece of information that says your muscle's in trouble, that's often probably enough, although it's gotten a little bit more complicated for a variety of reasons. So, there, okay. So, just a very, very brief anatomy lesson. Muscle is, in some ways, an extremely complicated tissue. And actually, in some ways, it's kind of a simple tissue because it's actually built of repeated units of the exact same thing. And so if you look at this picture, I don't even have a pointer here, do I? Anyways, is that going to work? Can I do that? I could do that. So if you start out at the level of a muscle, which we all recognize, you have basically pieces of that individual muscle, which is divided up into these little bundles, what are called fascicles, which are made up of a whole bunch of muscle fibers, which are made up of individual muscle cells. And the reason why I actually throw this up is to remind you that really at the base, muscle is made up of a whole bunch of cells. And really everybody remembers from grade 9 or grade 10 biology that you have these cells, they have all sorts of little structures inside, a nucleus, things that allow you to make proteins, things that run the energy of your cell, and it's all enclosed in this bag, essentially a membrane. And the problem is that when we're talking about muscle enzymes, what we're measuring is stuff that is supposed to be in the cell has now gotten out of the cell. It ends up in our bloodstream where we can measure it, and that's really the basis of testing muscle enzymes, of which we mostly will talk about 5 different ones. Now, depending on where you are, you may not be able to do all of these, and under different circumstances, some people prefer to do some people prefer to do others, although under ideal circumstances, you're going to do a whole bunch of them, and I'll show you why that's really important in a second. Now, all these things, ALT, AST, CK, LDH, and aldolase, they all end in ACE. And again, for anybody who remembers back to, I don't know, maybe grade 11 biology, if a protein ends in ACE, it's an enzyme. And the whole point of enzymes is that these are proteins that help with biologic reactions. It helps you to turn something that looks one way into some other way, to fold it, to cut off a bit of it, to insert something in the middle of it. It doesn't really matter. And it turns out that almost all of these enzymes are part of sort of the whole energy metabolism of the cell, how it basically takes food and turns it into energy, which is movement. And that's kind of why these are so important in muscle, because muscle's whole job in life is to essentially convert food into movement. Now the problem is, sorry. Okay. Did I just kick something or turn something on or off or? No idea. Okay. Stand back a little bit further. Sorry, nobody's ever accused me of being quiet, so microphones are sometimes a bit dangerous. So probably one of the things that I want people to understand is that people always talk about muscle enzymes as being these sort of really important things. They have a whole bunch of problems. And so the first problem is that diagnosis, only a proportion of muscle enzymes will be elevated. And we actually have some data. So one of my colleagues who I now work with in Halifax, when she was a fellow in Toronto, working with Brian Feldman, they actually looked at 84 consecutive brand new patients. And what they found is that only half of them had an elevated CK when they were diagnosed. So this is actually when they were probably at their worst of their worst. Only 85% had an elevated AST, 62% had an elevated ALT, and about 6% had an elevated LDH. And you can sort of look at the math of that and think, oh, there's a bit of a problem there. So what they've found in that particular group, and I think this is pretty consistent across most other people's experience, is that something in the ballpark of half of patients will actually have multiple enzymes elevated. But somewhere in the ballpark of 10% will actually have no muscle enzymes elevated. And so kind of the important message of that is that you can't rely on the muscle enzymes to say, oh, you don't actually have that disease. And we've actually seen that error happen not infrequently. Now, on top of that, we actually recognize now that muscle enzymes and how your disease is doing don't actually correlate that well. And unfortunately, finding data that actually says that is kind of hard, even though most rheumatologists who see lots of kids with dermatomyositis are completely aware of it. When we were validating everybody's favorite childhood myositis assessment scale tool, we actually looked at how well that tool correlated with muscle enzymes. And what we discovered was it's not very good. So a correlation of like 0.5 would be pretty good, 0.7 or 0.8 would be actually really very good. And most of the muscle enzymes correlated with how strong you were, kind of in the poor to hardly at all ballpark. And on top of that, and this study is actually a little bit old now, in kids who actually are clearly having a flare of their disease, so not at the beginning anymore, kind of the kids who have actually gone through some treatment and for whatever reason are having a worsening of things, only 2 of 22 had an elevated CK, which is kind of worrisome because people sort of think of CK as being this really important thing. Only 9 of 22 had an elevated ALT, although AST and LDH were actually a fair bit better. But there's a complication to that in that most kids who have dermatomyositis now be on methotrexate. And you can't really look at the blood work and say, oh yeah, this elevated LDH is because of their disease or is because of their methotrexate. So muscle enzymes require some caution how you interpret them. You can't rule out a disease diagnosis or a disease flare because they aren't elevated. And you can't necessarily assume that you actually are having a flare or a worsening if they are elevated. So you need to be taking context with a whole bunch of other stuff. And that's all I'm going to say about muscle enzymes. Because the next thing I'm going to show you is EMG. How many people in the room have had a child who had well, so like 2 or 3 or 4, yeah. So interestingly, that would be probably pretty consistent with what the literature internationally shows now. And so people who have not had an MRI or have not had an EMG, what is involved is taking something that looks a lot like an acupuncture needle with a little wire attached to it that goes off to a little sensor and insert that needle through the skin into the muscle. And what that generates is a little picture that looks kind of like this. So a whole bunch of nice little squiggly lines. Some people were not impressed with the whole idea of that. And the assumption is that if you actually have muscle that is ill, you basically get a variety of typical appearances. And people who really know what they're doing with this stuff can actually distinguish an inflammatory problem from a more congenital neuropathic or muscular dystrophy or those kinds of things, which is one of the problems that we're going to talk about in a second. So, but they sort of describe these appearances. You're supposed to have these short, small polyphasic motor units. fibrillations, which essentially means kind of rapid movements, and a variety of other kind of features, none of which are that important to you guys. Problem is, on the negative side, it's a needle. Most kids hate needles. Most kids with dermatomyositis are getting more than enough needles already. Additional needles are not much fun. But the bigger problem is that to get a blood test, you can kind of get through that. And you might need to be held down and distraction, all those other things. But to do an EMG, you need cooperation. So the needle needs to go into the muscle and sit there, and the kid not flailing around and not crying and not upset and all those other things, which actually makes it in particularly the younger kids, a really difficult test. Other problem, which is as time goes by, becoming an increasingly big problem, is you actually need expertise to do these things. So this isn't the kind of thing, if you go back to that little page of squiggly lines, I can't look at that page and say, oh yeah, that's normal, that's abnormal. That actually requires a significant amount of experience and expertise to look at. And in my center right now, the person who actually does our EMGs is about a year from retirement. And there's nobody else in our neurology division that actually does these things. So once he's actually gone, I'm gonna have to send my kids over to the adult hospital where they do millions of EMGs. And they're gonna have to go through the slightly negative experience of hanging out in an adult hospital, and I'm gonna have to convince him to look for the stuff that I need him to look for, or I'll get to stop doing EMGs, which is probably what will happen because I haven't done an EMG in about 10 years. Now, on the positive side, EMGs are potentially useful. They can give you information when the picture is fuzzy, and so that sometimes is just one more piece of information you can call upon. They are repeatable, not so much in the younger kids, but probably in the older kids. And they aren't actually that expensive, which is certainly a problem with some other tests that people might have need for. Now, the next thing I'm going to talk about briefly is biopsies. And so, I'm going to skip this picture because I actually have a much better picture in a second. We'll use that one because it's way clearer. So, muscle biopsies are kind of occupying this slightly weird place of being a really, really old test that we actually now have information that suggests that, well, gee, maybe it's actually a much more useful test than we thought it was for a while. And that's certainly something that we may want to discuss here a little bit. Historically, and this is not like going back decades, muscle biopsies were useful from the point of view of what you could see under a light microscope, which is what you're seeing here, with sort of fairly typical baseline staining. And somewhat more recently, what you could see under an electron microscope. And so the most important features would be what you can see in this picture here. If you look in the middle of this, each of these kind of little sort of kind of polygonal shaped things is one muscle cell. And you can see that the ones that are kind of in the middle here are way bigger than the ones that are on the outside here. And in healthy muscle, they're kind of all more or less the same size. There's some variation, but on average, they're kind of more or less the same size. And so this is one of the, probably the most important features of dermatomyositis, what we call perivesicular atrophy. So on the outside of the fascicle, things are smaller than they're supposed to be, probably related to ischemia or lack of blood flow. Now, the other feature, which you don't see very much on this biopsy, but if you go back to this one, and I'll do that so you can see a bit better, you can kind of see that out here, where you have a muscle cell here, and a muscle cell here, and a muscle cell here, there's not a lot of what you see in the middle here, which are all these dark blue blobs, are the nuclei of various inflammatory cells. So, and this little guy way up here is a very, very small blood vessel running in the middle of your muscles. So, again, typically the inflammation that we see in juvenile dermatomyositis is clustered around the blood vessel in the biopsy, which is sort of goes by the sort of the slightly more fancy name of perivascular infiltration, or basically lots of inflammatory cells coming and hanging out around that blood vessel. Now, it turns out that if that's all the information we can get from muscle biopsy, most kids probably don't need a muscle biopsy to figure out what their diagnosis is. Ready? If a 7-year-old girl is brought into the clinic and she's got typical Gottschalk's lesions and a typical heliotrope rash, and she's having trouble walking up and down the stairs and can't comb her hair in the morning because she can't get her arms up, really, she probably has dermatomyositis. The biopsy is not going to tell me a whole lot more than that. Now, that's not the only circumstance we would necessarily want a biopsy, but there are definite limitations to what a biopsy is going to tell us about a kid who actually is otherwise pretty typical. Now, the kids who are atypical, the kids who don't have rash, the kids who have unusual features are much more problematic. And then there's a group of kids who you thought were perfectly straightforward, and 2 years in, they failed everything that you could do for them. They're not doing very well, and now you're questioning, oh, gee, do we have the right diagnosis? It's hard to go back and biopsy them after 2 years of treatment and totally understand maybe what you might have missed before they were diagnosed. And that certainly has been one of the arguments people have made about having muscle biopsies available up until more recently. And so more recently, there's a number of new techniques, new ways of looking at muscle biopsies that actually probably give us information that we never were able to get before. And so I don't actually, I had that on my other presentation, but there's a number of different stains you can use as to what kinds of inflammatory cells have decided to show up in the muscle that don't belong there. What's happened to blood vessels, because you can stain for blood vessels that are too small to see. What has happened in terms of what kinds of proteins are living on the surface of the muscle cells that aren't supposed to be there. Those features probably have a couple of important roles. One is that they can help you verify a diagnosis when it's not quite clear. Probably more importantly, though, it's looking like how many of those features are appearing in a muscle biopsy versus not appearing in a muscle biopsy may actually be able to give us information about the underlying phenotype, helping to predict course, and hopefully, although probably not quite there yet, influencing what treatments are more or less likely to be effective for any individual kid. Because as you've heard probably repeatedly over the last few years, the goal is to stop thinking about dermatomyositis as a single disease and trying to figure out what are the different groups within that. Because probably some of them are better off with higher doses of steroid, and some of them are probably better off with rituximab, and some of them are probably better off with mycophenolate, and some of them should never get methotrexate because it's going to be a poor choice. And we are far from that, but biopsy may be becoming another one of the tools we can use to figure out how do people fit together. So the UK group has been an absolute leader in this area. So Lucy Wedderburn, who, if you ever have a chance to invite to something, is fantastic. And over the next few years, hopefully we're going to get a better idea as to what the real role of muscle biopsy is. Right now, I would say that it's kind of changing. I'm not sure if anybody was thinking about it, but I'll sort of throw out, looking at 2 big data sets in the world with like about 1,000 kids total. About half of kids still get a muscle biopsy. And that's actually common in Europe and the United States and Latin America. So it doesn't actually even matter where in the world you're from. 50-50 is about where things are right now. But certainly over time, people have gone from everybody getting a biopsy to being much less likely to do biopsies. So the nice thing about biopsies is they are important sometimes for confirming a diagnosis. They may help to predict what's going to happen in the future. And if there's ever a question about what the diagnosis is, sometimes they actually become very, very important. But they have lots of negatives. Surgery is not necessarily something that everybody wishes for their child. They hurt. They leave a scar, all of which are significant negatives. There is a question about whether a needle biopsy, where you basically are taking a muscle sample simply using a needle, might be effective. And there's actually very little data in kids. They are used in adults now, although what they're looking for in adults is sometimes quite different. And it's a bit unclear as to whether needle biopsies are going to be amenable to some of these new techniques and new stainings we have available to us. Some of you may be in centers where needle biopsies are being used. In, again, the same 2 data sets that I just mentioned, somewhere between a quarter and a third of kids were actually having a biopsy that was done with a needle. Unclear as to how many of those kids had a biopsy that was helpful or not helpful. So again, data is just not available. Okay, so MRIs. Oh, absolutely, yeah.
So my daughter, was diagnosed 7 years ago, and she did not get a muscle biopsy, and she has a really refractory case, like hard to treat.
Yeah.
So are biopsies only valuable at treatment, like before treatment? I'm sorry,
so
at diagnosis.
I would say so. The answer is no. You can definitely do a biopsy down the road, either because you never had one before or you're trying to figure out what's going on. The challenge is trying to figure out sometimes what the influence of 7 years of treatment, 7 years of disease has had on the muscle, and at that point, it's possible that there's been some damage caused by the inflammation. So now you're looking at scar tissue, and it's hard to know what to make of that. And if you're trying to figure out, okay, well, is the diagnosis actually something else? The years of disease and the years of treatment may or may not make that harder or easier to look for. But if people aren't sure what's going on, certainly a muscle biopsy is one way of trying to go back, maybe not to the beginning, but going back to first principles to try to figure out, okay, well, why is this refractory? Is it because we have the wrong diagnosis? Is it because we've used the wrong combinations of treatments? And sometimes we don't know. But certainly it's not unreasonable to do a biopsy down the road on the assumption that everybody recognizes that, okay, now you need to figure out how to incorporate all the things that have happened for 7 years into that interpretation. That's a really good question. Another question up here.
I got a question. My daughter just diagnosed at the end of 2015. So the symptom for her is the rash on the face and neck and chest, but not on the doesn't show weakness on the muscle. So as I heard that it's benefit to have the muscle biopsy before the treatment. So for her scenario, do you suggest to do that approach, have a muscle biopsy?
Not necessarily.
Okay.
Again, we're at a point now where it would certainly not be appropriate to say everybody needs a muscle biopsy. And depending on what the question being asked is, it may or may not add a whole lot. Really, I'm not sure if your child had an MRI or some other way of...
Yes, she have MRI.
So with typical rash and an MRI, that may be enough to make a diagnosis. In reality, at this point, if things are going well, there are no other questions, adding a biopsy probably isn't going to make a big difference. If, on the other hand, things are going badly, then maybe it's time to sort of take a step back and say, okay, well, you know what, maybe something's not quite what we expect it to be.
Another question is, you say is the negative impact for that is surgery and painful. Could you help me to understand what do you mean surgery? Is it cut? What will that be?
In
like?
most centers, children will be asleep for this. So they go to the operating room, they go on a breathing machine, anesthetist looks after them. And that's not the biggest deal in the entire world, but there's a small risk to that. They make a small incision, usually on the outer thigh. Incision's probably yay long. So it's not like massive, it's not like having abdominal surgery or something, but so you actually do end up, they basically make an incision, they take a little piece of muscle, send it off to the lab, and then they sew them back up. So they have stitches, they have a scar on their leg, which may or may not be a big deal, depending on, some kids will end up with a scar that looks very impressive because they tend to lay down extra scar tissue. Some kids have a very small scar. It varies. So it's not a big surgery, but it is a surgery.
Thank you.
Okay, so I was talking briefly about MRI. And so people sometimes are a little bit confused about what MRI involves. And so the principle of an MRI involves two important things. So one is that all of the cells in your body are made up of a whole bunch of different atoms. And in those atoms, they actually all behave like little tiny magnets. And under normal circumstances, they're all kind of pointing in random directions. And so on average, there's no sort of general direction. If you apply a magnetic field to anything, whether it's a human body or a hamster or a block of cheese, particularly the water molecules, because they have lots of hydrogen in them, will actually, a proportion of them will actually flip that magnetic field so they're all aligned. And so it's kind of what they're showing in this little picture here, where you go from things pointing in all different directions to things generally pointing in the same direction. When that happens, and then when it's essentially unhappens, it releases a small amount of energy, which can be picked up by the MRI and then gets sent off to a computer, and they sort of essentially take that information and generate the images that you get to see. So it doesn't involve X-rays, which is a huge positive because X-rays certainly have risks that magnetic fields don't have. But it also means there's certain limitations. So you need to actually have the information collecting stuff very, very close to where you're looking. And so you're in big machines with them really, really close. I've actually had an MRI a couple of years ago, and it's really, really, really close. You have to have the coil that's around you, literally within probably a few centimeters of your skin. And if you're not crazy about loud noises and cold spaces and tight spaces, it's not an awesome experience. Now, most of the time, MRIs are basically trying to show us water that doesn't belong. And so most of the sequences are set up in a way such that areas that have more water in them than they're supposed to will light up. And it turns out that you might get pictures that look kind of like this. And people in this room don't need to be physicians to recognize that this is really, really, really white, and this is kind of not so white. And really all the muscle should be this nice dark kind of uniform color. And this muscle is very inflamed. And the layer on the outside of the muscle or the fascia is extremely inflamed. But there's another couple of things about this picture that actually are also important. One is that it's not uniform. So this is the same patient, the same leg, and back here it looks pretty good, although there's probably a little bit of inflammation on the outside. And this muscle here, which is right beside it, is actually very, very hot. And if I show you my other picture that I have here, even within a muscle, you can see that this part's really white and this part's much blacker. Over here, you can kind of see this part over here is very, very white, and over here is less black. And these pictures that sort of show standing up, there's no real symmetry. So the muscle here is white. On this side, it looks a bit better. Way up here, you've got areas that are white, and it's kind of similar here, but probably a bit whiter there. And so one of the nice things with MRI is it basically gives us this kind of wider area. So if I do a muscle biopsy, I get to look at a little piece that's about this big under a microscope. And if I was lucky, I got a part of the muscle that was abnormal. But what if I accidentally biopsied, where did this go? There we go. What if I actually biopsied this nice normal looking area over here? It's possible my biopsy is going to be totally normal, and so now a kid has gone through a painful procedure, and now my biopsy is normal, and I don't know a whole lot more than I did before. Now, it's probably a bit more complicated than that, because not everything that lights up an MRI will have an abnormal biopsy, and unfortunately not everything that is normal on the MRI will have a normal biopsy. So it's a bit more complicated, but people have certainly advocated MRI as a way of picking the right spot to biopsy. What's the most inflamed tissue? And gee, if the right leg looks really good and the left leg looks kind of terrible, you should probably do the other side, no matter what the surgeon thinks. So MRIs have a number of advantages. So they aren't particularly invasive, although they are kind of creepy. You can repeat an MRI, and I have kids who've had MRIs yearly because it was the only way we could really figure out what was going on. They let you look at a large area, and some people have actually advocated for total body MRI recently, where not only you're getting a picture of the thighs, but you can actually look at the shoulder girdle and the axial muscles and the distal muscles and the proximal muscles and the whole shebang. And they sometimes will actually help you figure out what muscles are actually the most involved, which will help you target things like a biopsy. Now, unfortunately, they're really expensive. And that doesn't really matter where you are in the world. They're always really expensive. Access can be problematic, either because you live in a very small community or a very poor place, or you don't have insurance coverage, or whatever the circumstance is, depending on where you live. They can certainly be really scary. And the thing I haven't actually mentioned here, not only are they a bit scary, but you have to lay really, really still for 45 minutes or an hour. I don't know how many of you guys have kids that will lay still for 45 minutes, but mine definitely won't. Most of the time, the very young kids need to be sedated because there's no chance you can put them in an MRI. I have one 5-year-old who had an MRI without sedation, but typically anything less than 6 or 7 pretty much requires sedation, and sometimes the older kids even need it. And it is possible to have an MRI that looks like it's inflammation, but it's something else. And it's possible to have an MRI that looks totally normal, but have a biopsy that's abnormal. So it's not a perfect test, although it actually is really good. It's really quite good. Turns out that when we actually look at the big data sets, about 90% of kids in North America get an MRI as part of their evaluation. So MRI is probably done more commonly than any test other than muscle enzymes, much more common than biopsy, much more common than EMG, and to some extent has become kind of the, I don't know, de facto test that would help you figure out is there or is there not muscle inflammation. Now, I have two very, very quick slides I'm literally going to kind of gloss over. There are a number of other blood tests, and depending where you are and who your rheumatologist is and what decade you happen to be being seen, there have been other tests that have been suggested, are used by some people, but have not become sort of generally used. So there are some tests called neopterin and quinolone, which some people think are fantastic, but you couldn't go to your local lab and say, I need a neopterin test done. Factor VIII-related antigen is related to the coagulation system, and certainly in some kids seems to be a really, really good test, but for reasons that are unclear in other kids, it doesn't seem to correlate whatsoever with what's going on. Go ahead. Yes, yeah. And then some people are quite convinced that they can measure certain immune cells, like B cell populations or subcells of sets of B cell populations, to tell them where things are. That's one of those things that some people are totally convinced about and other people are totally not convinced about. It hasn't really found its place as a standard test. Now, Dr. Kim's going to talk briefly about myositis-specific antibodies, so I'm going to say nothing more about those. And I will actually just sort of point out that there may be a whole lot of other tests that kids who either have or are thought to have dermatomyositis may need to figure out other issues. Is there another diagnosis? Are they developing another autoimmune disease? Do they have some sort of an immune deficiency? Those kinds of things. So the tests I've talked about here are not necessarily the whole spectrum of stuff that people would get. Now, the other thing I'm going to say is the future, hopefully, is going to be much better biomarkers or biological markers that are going to help us figure out who actually has the disease. And I think actually more importantly, because once somebody thinks about dermatomyositis, it's usually pretty easy to make a diagnosis. Trying to figure out how active things are, whether things are going well or badly. And the problem is right now, we're still relying on kind of slightly archaic things like how strong you are and what does your rash look like and what do your muscle enzymes look like. But hopefully we're actually going to find either genes we can measure in your blood, protein products, cytokines, other kinds of things we can do a blood test on that say, oh, you know what, you're 50% better, you're 20% better, you're flaring, you're in remission. Those things we don't actually have yet, but hopefully is coming. And then some people are really interested in looking at ultrasound and trying to figure out whether ultrasound could replace some of the other imaging. Problem we have probably right now with ultrasound is that it's extremely operator dependent. So you need to have actually done hundreds and probably thousands of muscle ultrasounds before you're good enough to be able to say, yes, this muscle is inflamed versus no, this muscle is not inflamed. And there certainly are concerns about whether it still gives you enough information about structure and is there scarring and all those kinds of things. So that may be something that happens like in the next 5 or 10 years as this ultrasound technology gets much better and we understand more what its role is. But probably right now, ultrasound is maybe an adjunct or a little bit of extra information, but it's not going to be the bottom line. So I'm going to turn things over to Dr. Kim for a second.
So I'm just going to talk briefly about one last laboratory test, the Myositis Autoantibodies. So up to 80% of kids with juvenile myositis can have these autoantibodies. So that's when the body develops something in the immune system that detects something is foreign within your own body. And it's seen more specifically in myositis versus other things. Can be associated with some distinct features or symptoms that are like more specific to that myositis antibody group, like we've heard some about from this morning's session. And there may be some associations with different outcomes based on what autoantibody someone has. Oh, I think the slides got out of order, so I'll just do the next slide. I think the slides may be later. Yeah, they may be later, so I'll come back to it, but yeah, sorry about that. So I'll just give an overview of what the treatments, and I'll come back to the autoantibody slides later. So for treatments, we know that all the treatments that we use are generally targeting inflammation in the body, and they all have their own side effects, but we were going to give an overview of what they are, kind of how they're given, and what the key side effects are. In general, the first-line agents, or the treatments most oftenly given, are definitely steroids, number one, and methotrexate is probably the next most common medication that's used. And often adjunct, or like kind of supplement, not necessarily primary medication, is hydroxychloroquine, which is also known as Plaquenil. And other agents that are sometimes added on to help lessen your dose of steroids, or if you need more aggressive therapy, are intravenous immunoglobulin, or IVIG, mycophenolate mofetil, which is also known as Cellcept, cyclosporin or tacrolimus, azathioprine, rituximab, and cyclophosphamide, which is also known as Cytoxan. For these ones that are italicized, we may not get to based on time, but I'm just listing them all here, and we can go through all of them in detail if we have time or if you want to. Okay. So next, we'll go back to Dr. Huber with steroids. I think
Hopefully we'll get to all of our picture. Okay. So anybody who's not a big Marvel fan can probably take a break for a moment. So I usually think of steroids a bit like this large green guy. So they're really powerful. They're really effective. They have a tendency to be a bit indiscriminate and to cause a fair bit of damage. So they work, but they tend to leave some problems behind. So I'm going to walk you through a little bit as to how steroids actually work for a second, because I think it does actually help to solidify a little bit, okay, well, why do we use these things still? And why are they actually still at the front of what we need to do? So if we start way up at the very top here, and it doesn't really matter whether we're talking about prednisone or prednisolone or methylprednisolone, whether it's oral or IV, mostly it all comes down to the exact same thing. So it doesn't actually do anything. Okay, where'd that go? There we go. Disappear. Okay, fine. The steroid doesn't actually do anything until it actually gets into the cell. So unlike some things which have to bind to the surface of the cell or bind to something outside the cell, it actually has to get into the cell, at which point it then binds to a receptor inside the cell. And once it binds to the receptor, then it can actually go places and it can actually go do things. And it turns out that what it actually does is to actually end up going into the nucleus. So basically into the business end of the cell where all the genetic information is. And it actually will bind with its receptor to the DNA and will influence what exactly proteins that cell's making. Now, as you can appreciate, from a dermatomyositis point of view, we actually know that steroid binding to the DNA in the nucleus reduces a whole bunch of the things that generate inflammation, which is great if you have dermatomyositis or asthma or lupus or any other disease where inflammation is important. But you can appreciate that while it's in there, it can bind to all sorts of stuff. And that fundamentally ends up being the reason why steroids are a medication that does literally, I don't know, thousands of things. It depends on how you add them up. So once that actually has happened, the steroid actually is not doing anything after that. By actually influencing what genes are turned on or turned off, it results in different proteins being made or not made, which then results in the effects of that it has. So you make less of the pro-inflammatory type cytokines, you make more of things that actually reduce inflammation, but you do a whole bunch of other things. Now, am I going to have a pointer again? There it is. Excellent. So up here, you have steroid. Down here, you have steroid. This is just a very, very simplified representation of the effects that steroids have on the immune system. This doesn't actually get into all the other things that steroids do. And it turns out, there we go, that steroids affect all sorts of different cells in your immune system. So it affects all sorts of different T cells, which are really important in lots of autoimmune type reactions and helping you fight infections. And it actually affects most of these by interfering with things like TNF and IL-1, which you heard a little bit about this morning from Dr. Ryder. It inhibits how macrophages work, which are cells that run around cleaning things up and eating up invaders. It interferes with all sorts of other cells up here, including cells that like to influence the immune system called dendritic cells, affects B cells, which are the cells that make antibodies. So lots and lots of different effects. And at the same time, it's also affecting all sorts of other cells down here. So osteoclasts are bone cells that break bone down. And you'll notice that the arrow is black and has a point on it, which means it actually stimulates them, which is part of the reason why bones have a bit of a problem with this. And at the same time, it actually affects osteoblasts, which are bone building cells, in a negative fashion. So it basically tells your bones essentially to break themselves down. It affects cells in the cartilage, it affects cells in the fat, it affects cells everywhere. And part of the reason why this happens is that, to some extent, steroid hormones are not foreign to your body. So every day we all make a variety of steroid hormones. The steroid that's the most similar to prednisone is one called cortisol, and it has lots and lots of effects. So not only is it important, there we go, in how your body handles sugars, which is why diabetes is potentially important. It affects how your liver detoxifies things. It affects brain tissue, memory, learning, sleep, mood. It affects all sorts of endocrine stuff because ultimately cortisol is an endocrine hormone. It affects where fat and weight are, your body composition, how your body handles protein, whether your skin is actually intact or weak, has all sorts of effects on the musculoskeletal system, which unfortunately results in us always being able to show a diagram that looks kind of like this that says, here's all the bad stuff that prednisone does. And everybody in this room has a kid who's been on prednisone, almost certainly, and you've probably experienced some, many, all of these different things. I'm not going to go over this because this is not stuff that we necessarily need to talk about in detail. But I tend to like to think about prednisone side effects. So I'm talking to families when we're kind of at the point of we're going to need to use prednisone. I tend to divide them up into this group of things, which are the things that are really, really common, that families are almost always going to experience, and are really distressing for kids and their families. Although, to be perfectly honest, as a physician, I'm less concerned about this group of stuff and more concerned about the next group of stuff. But things like being hungry all the time, things like being irritable, not being able to sleep particularly well, getting up at night to go to the bathroom, which nobody writes about, but all my kids tell me about. Gaining weight, changing their appearance, developing acne when you're 7 years old is a little bit weird. Stretch marks, hair growth, none of these things are serious or life-threatening, but they're awfully unpleasant. They make the quality of life a huge problem, and certainly are very distressing for kids. Now, unfortunately, as a physician, I'm actually more concerned about this stuff. So kids on prednisone don't grow. So that's a problem. Kids on prednisone have weakening of their bones, so they're at higher risk of developing fractures, sometimes with minimal or no impact at all. They can develop high blood pressure, they can develop high blood sugar, they can be susceptible to infections, they can develop eye problems, liver problems, bone problems. Mental health can be exacerbated by steroids. And unfortunately, ever so often steroids make you weak, which is a bit problematic in a disease where weakness is an important feature. Now, the other thing that we always emphasize, in fact, we actually give families some written information about so they can take it home. Yeah, go right ahead.
Hang on. Sorry. Quick question. When listing all these wonderful side effects, which
awesome.
Children may be susceptible to, how does length of time or amount of exposure relate to that? In other words, if a child is only exposed to steroids for 2 years, are we still going to see those side effects if they're exposed for 4 years? I mean, how does that all work?
So that's a really good question, and it's actually more complicated than I think some people appreciate. So the first thing is that some people are more or less susceptible to these side effects. So I'll give you an example, kind of one of my more memorable patients. Girl with sort of moderately bad JDM. Really, she was still playing hockey, although it was impaired. She wasn't super weak. She was pretty rashy. Came into hospital because she was basically a little bit too weak to really be safe to go home. And basically started on kind of standard steroids and standard dose and methotrexate. Within 3 weeks, she was on insulin for her diabetes. She gained 10 kilos. She had multiple spine fractures, although probably not just because of her steroids. She developed kidney stones. and had developed a recurrence of herpes zoster infection on her backside, and so couldn't sit down. And that was 3 weeks in. For whatever reason, probably genetic, she is exquisitely sensitive to steroid side effects. Now, unfortunately, she wasn't particularly sensitive to steroid impact because she actually didn't get better as quickly as I would like her to have. So we actually had kind of the worst of both worlds. I have another boy who's been on prednisone, never lower than 10 milligrams for the last 5 years. And I would have to say you wouldn't bump into him on the street and suspect that he was on prednisone because he's actually experienced almost no side effects. So the first answer to your question is it varies. And some kids are going to be much more susceptible than other kids. And sometimes we know really, really early that this is a kid that we have to get off steroids much, much faster because they obviously are very, very toxic. And other kids tolerate the steroids, and it's kind of a minor issue. So there's a fair bit of variation. The other piece, which I will come back to you, the other piece that's really important is duration is probably much more important than actual dose. So if I give you 3,000 milligrams of steroid over 3 days, you're going to have many fewer side effects than I give you 10 milligrams of prednisone a day for a year, even though the actual number isn't a whole lot different. And that actually is one of the things that's a little bit challenging. And it's one of the reasons why some centers are very, very aggressive with using IV steroids and trying to use less oral steroid. However, if you use a lot of IV steroid over time, you probably end up in the same place. So there is a bit of a balance. 2 years of steroid is definitely better than 4 years of steroid, but 2 years of steroid is still a long time. And when I finished my training, which is now kind of an embarrassingly long time ago, pretty much everybody was getting 2 years minimum steroid, and lots of kids were at 2.5, 3, 3.5 before they were actually able to get off their steroids. But most places are trying to get kids off kind of within a year or so. Some centers are more aggressive, and sometimes you can get away with that, sometimes you can't. But really, I think the principle is that duration is much more important than total dose. And yes.
I know we talked about side effects kind of resembling like Cushing's syndrome, things like that with their adrenal functions.
Yep.
Our daughter, we've looked at and hadn't been on steroids until now, 3 years in, when she's just not getting better, and overlapping of scleroderma. So now she's on 750 milligrams of IV steroids, and her ACTH function level is like non-existent on blood work. If they stimulate it, it shows up. What do we have to worry about with steroid use and the adrenal functions with a kid who's got adrenal issues?
Funny you should ask that question, because that's what this slide is.
Okay, well that's what I was,
Yep.
I had it before you got to this, and then
Yep.
I was like, I kind of wanted to know because of that stress aspect. We had an issue in the hospital giving the flu shot, pretty much almost made her almost anaphylaxis, and it kind of worries me because they were talking about giving her stress prednisone after they just gave her 750 milligrams of prednisone. And so I kind of wanted to really know about that because the doctor couldn't answer my question when I asked her.
So let me go through this and we'll try to come back to that a bit more specifically. So we've already sort of talked about the fact that your body needs steroid for normal function. And it needs basically cortisol for a lot of normal functions. Often when we're sort of thinking about steroids, we sort of think about this as being kind of the stress hormone. And when your body undergoes stress, whether it's an infection, whether it's surgery, whether it gets in a car accident, your body's response is to generate a whole bunch of steroid. I sort of think of it as sort of, this is winter's coming, it's time to hibernate. And if you sort of think about some of the side effects, really get really hungry, eat a whole lot, you gain a bunch of weight, because something bad is about to happen. And that's kind of what being on a big dose of steroid is telling your body is going on. Now, the problem is that if I give you a whole bunch of steroid, your body's adrenal glands essentially say, there's lots of this stuff around, I don't have to do anything. It turns all its own machinery off. And if you then suddenly stop taking steroid or don't have any steroid on board, it doesn't have the ability to actually release that stress steroid that you need. And in that circumstance, you can get really, really sick. And that might be something very, very mild, like some fever, some belly pain, headache, vomiting, being a bit sleepy. Or you can drop your blood pressure into your boots, or your brain can swell, or you can die. And it's one of the reasons why people who are on steroids probably anything longer than, say, 2 or 3 or 4 weeks, and it sort of varies what the recommendations are. There are recommendations for essentially what people call stress dose of steroid, which essentially means that when your body's under stress because you have an infection, you have a fever, you're going to have surgery, that you basically give enough steroid to cover that sort of stress. Now, usually not prednisone. Usually it's given as either Cortef, which is cortisone, or it's given as an intravenous, or even if it's an emergency, it can be given as a sub-Q dose of Cortef, which doesn't have much in the way of anti-inflammatory effect, but it deals with that blood pressure kind of piece, which is really the piece that people get into a lot of trouble for. Now, unfortunately, families that haven't actually experienced that sort of decompensation sometimes are a bit blasé about it. And actually, I have a patient who doesn't have dermato, who has systemic arthritis, who's been on prednisone for like 10 years and is now down to a dose that's below what her body would normally need for stress. She got kind of a cold and ended up in the emergency room and almost in the ICU because family sort of thought, oh, she's not particularly sick, we're not too worried. And they didn't give her the little bit of steroid that was sort of planned. So the kids can get really, really sick with that. Now, how much stress constitutes stress is a little hard to quantify. So, gee, if you just have a bit of a cough but you don't have a fever, maybe not. But if you're febrile, certainly if you're having surgery, but maybe not if you're having dental procedure. And we tend to tell the families that if in doubt, go ahead and give that little bit of cortisone. And the reason for that is that cortisone is a much less potent steroid than prednisone is. So it's probably about 4, maybe even as much as 5 to 1. So even though you're being told to give 10 milligrams of Cortef, it's like 2.5 milligrams of prednisone. It's kind of nothing. And in the big scope of what your child's experienced, it probably doesn't make any difference, particularly for that 2 or 3 days that you're going to give that stress dosing. Harder to know for something like blood work, although theoretically, if she was worked up enough about it, I could imagine that, okay, yeah, it might be enough. It's hard to say. Does that answer any of the questions? Yeah. Right. I definitely, given the fact that your child just had 750 milligrams of Medrol, giving another 10 milligrams of Cortef, it's nothing. It's like probably less than 1% of what she's already had. So it might keep her safe because that medication's kind of come and gone already, but you need the stress piece. So question back there?
Yeah, so we're about 10 months in to prednisone use, and he's seen all the less concerning side effects that you mentioned, but we just saw this week cataracts in both eyes. So 2 questions. One is, does that mean that he's more susceptible to more concerning side effects of the prednisone that you have on your list? And second, should we be more aggressive coming down?
So the answer to the first question is we probably don't know. There's no doubt that some kids develop some complications really, really easy. There's no data that suggests that if you have one, that you're at risk of all the other ones, but I would certainly be a little bit worried about that. And generally speaking, if it can be done safely, if you're actually experiencing one complication, really, you don't need any more, because unfortunately, the longer they're on steroids, the worse the cataracts are going to become, and you'd like to get them off their prednisone before the cataract becomes something that's actually going to require intervention. Because often those cataracts, they're small, they can see around them, it doesn't cause any impact on vision, and as long as you get them off prednisone, it doesn't tend to continue to grow. Well, at least not until he's 70, but that won't be your concern at that point, probably. So the last slide I have is sort of how do you avoid steroid side effects? And unfortunately, you to some extent you can't. You can be lucky and have the right genetics and be able to tolerate steroids without tremendous side effects. But obviously nobody can choose that. And really the only way to avoid steroid side effects is to avoid steroids. And how do we do that? The whole duration is more important than dose. And so some people have taken the approach of giving upfront IV big doses and not every day. Some people think that's a super important approach. Other people are less convinced. Use of steroid-sparing medications and the transition from prednisone alone to prednisone plus methotrexate may still actually be the single most important thing that's happened in treatment of dermato, certainly in the last 50 years. And there certainly is reason to believe that if you treat aggressively up front, your overall exposure to steroid will probably be less than if you tried to go gentle at the beginning and then 6 months in, things aren't going great, you have to go back up. And you end up getting more steroid in the long run because you tried to avoid the steroid up front. So probably being aggressive up front is helpful. Although, again, that's not the kind of thing where anybody's ever made a direct comparison to those two things.
Go ahead. Just briefly, I'll start by going over the myositis autoantibodies. So the most common one seen in juvenile myositis is called anti-TIF1, or it's also called P155 or 140. And these pictures are taken from one of Dr. Ryder's articles. So this autoantibody group, if someone has myositis and they have this antibody, it's more associated with having UV or sun-sensitive rashes and kind of having a chronic disease course, so over a longer period of time. And the next most common antibody is an anti-NXP2, or it's also been called anti-MJ. This is associated with having more muscle pain or cramping, and calcinosis, which is the buildup of the calcium in different parts of the body, and more likely to be hospitalized. And the third most common, which is being better studied more recently, is called anti-MDA5. It's associated with some general sickness symptoms like fever, weight loss, and fatigue. You're more likely to have some lung disease, and you can have open skin wounds or ulcers and arthritis. And one thing I wanted to mention about these autoantibodies is though they can be done in many different labs, they're done with different procedures that have variable reliability. So at least in the US, we really recommend having them done through a particular lab, this Oklahoma Research Foundation lab, and this is a website for that because it's done with a more specialized and more reliable result. And then a couple of the other antibodies that are less common, one is called anti-MI2, and it tends to have more of the classic rashes, like the malar rash on the face and the bumpy or Gertron's papules on elbows, knees, and knuckles, and typically is associated with having a better response to therapy. Anti-synthetase antibody is more common in adults. It's not that common, 2 to 4% of juvenile myositis, but it can be associated with more arthritis or inflammation in the joints and having a distinct hand rash that's not necessarily seen in others with myositis, where they have rough or hands, also it's been called mechanic's hands, and tend to have more lung disease, which can be severe and even fatal sometimes. And anti-SRP is another antibody, which tends to be more seen in polymyositis, not very common overall in juvenile myositis. They tend to have a very high muscle enzyme, in particular creatine kinase, or CK, very significant weakness, and on muscle biopsy, they had more signs of cell death, which is also called necrosis. So all of these features are not 100% only with that antibody, or like not everyone with that antibody has those features, but there are some associations that have been seen by further classifying with these antibodies. Okay. So now we'll go through some of the other medications. Next medication we'll talk about is methotrexate. So in general, I'll show some pictures for how the medication is administered, and I'll have a general dose on there just for reference. So methotrexate can be given by mouth as a tablet, and it can also be given as an injection. And this medication is given once a week. And that's because they found that that's the best way to get the effect of the drug and limit side effects, particularly the liver enzymes being elevated side effect, which we'll talk about. Methotrexate works in a lot of different ways, but one way we know that it works is that it competes at this particular spot in pathways related to DNA synthesis that have to do with folate or folic acid. And in general, a lot of the medications that we use affect immune cells to help decrease inflammation. So you can see, well, it's hard to see from this complicated diagram, but methotrexate does help decrease the immune system and immune cell activity. So the most common side effect that we see with methotrexate is belly pain, loss of appetite, nausea, and intolerance. And a lot of times we hear, and you may know from your kids' experience, that they may develop kind of an intolerance or kind of an anticipation of the side effects, that they know that it's going to happen, and they may start feeling nauseous even before they get the medication because it happens so frequently. Another thing that can happen are sores or ulcers in the mouth, which this picture shows. And some people have a slow hair loss or mild hair loss. It's not bald patches, but it can be like a thinning of hair that can be seen. Overall, we know methotrexate was originally developed as a chemotherapy, and it's used as much higher doses as a chemotherapy, and you may find information about that if you look it up, but the doses that we use in juvenile myositis are much lower, and it's generally considered pretty safe, and we have data from its long use in chemotherapy as well for safety. Generally, these side effects are diminished by the adding folic acid as sort of a vitamin to help with these side effects. It's taken once a day, so oftentimes they're started at the same time, methotrexate once a week and folic acid once a day every day. Other things that can be tried to help with the side effects are reducing the overall dose of methotrexate or switching from taking it by mouth to injection has helped with some of the side effects for some people. So with folic acid, we know that the methotrexate acts at around that area in that pathway that I showed, but even with this dose of folic acid, it's mainly just helps with the side effects, but you can still get the effect of the medication, which a lot of people ask about.
I've just heard mixed things about taking folic acid on the day.
Hold on just a second, please.
I've heard mixed information about taking folic acid on the day of shot day. Our doctor says it's fine, but I hear different things, so I'm just wondering.
I don't think there's any absolute data, but I also have heard, and different doctors may practice different ways, but some people do say to skip it on the day that you're getting the methotrexate so you can get the most effect from the methotrexate. But there are others that just take it every day, and I'm not sure that makes a huge difference. I don't know that there have been any studies to prove it. It may help not to take it that day, but it's okay also if you take it that day.
Going back to your slide on the how your body metabolizes the methotrexate. So the MTHFR, now when you have a genetic mutation with that and you're positive like the A1298C and the C677 one, now taking methotrexate, because I've often wondered this with our daughter being positive, the 2 genetic variants, and has a higher incidence for like homocysteine elevation. Now, is the methotrexate, is she able to even, I mean, we're on it, but no one's ever been able to answer my question since this has to do with, going through the methylation process. Is there an issue with being positive these gene variants and trying to take methotrexate as well as folic acid since it's a folate issue?
This is a good question. I don't know that anyone studied that in particular, and I think I and probably others have also had patients that have MTHFR variants or changes, because that's not in the overall scheme of things that rare. A lot of people may have that, and it's been most studied to be associated with clotting issues, like you may probably have heard. I haven't heard anything about it being a contraindication, so I think it's probably okay, but it's something that we may learn more about in the future. I know it's in the pathway, but there are a lot of redundancies in these pathways, and in general, you'll probably notice a theme that a lot of the medications we use, they block something about development of DNA building blocks that affect the immune cells, but there are a lot of different pathways that can lead to that. The next thing that's not something that you feel, but it's commonly seen, so it is concerned from the doctor's perspective, is that their liver enzymes can be high. This is a picture of the liver. And also you can have lowering in different blood counts, like your white blood cell count or your red blood cell count. So that's a reason why there are frequent blood draws, or you'll probably have blood drawn every time you see your doctor to monitor for those side effects with methotrexate. And then in general, because we know this medication suppresses the immune system or affects how the immune system functions, you may have a decreased ability to fight infections and increased risk for infections. One thing that people have talked about, and you may have heard, is your doctor will always ask you if you're getting sick to let them know, particularly if you're on antibiotics, because a lot of people will hold your methotrexate, so tell you to stop taking the methotrexate while you're on the antibiotics to give your body a chance to fight the infection until you're done, for example. And then we know that surgery is a major stressor on the body, so a lot of times we may hold methotrexate to allow your immune system to be able to fight that stress before and after major surgery. And then in general, some other things, if for people who have immunosuppression, We recommend not to get any live vaccines during that time. So in general, most vaccines are a way for your body to get exposed to a bacteria or virus, and then for your body to learn how to fight against that if it's ever exposed in the future. And a lot of times it's just with a piece of the bacteria or virus that's like killed and it won't cause infection. But a couple of the vaccines use a weakened but still live version. Some of the examples are in the MMR vaccine, mumps, measles, and rubella or varicella. And some types of the flu vaccine, like the nasal spray, those are live vaccines. We recommend not getting those because you may be at higher risk of really getting the infection, whereas someone with an immune system wouldn't get the infection with the live vaccines. And then just general good hand hygiene, like hand washing, and trying to avoid direct contact, close contact with people who have infections, of course. And just so you're aware, we know that methotrexate can cause problems during pregnancy, birth defects in pregnancy, and it's not recommended or shouldn't be used with someone who's consuming a lot of alcohol because we know it has liver effects, or if they have some other underlying liver disease, or if they are already known to have low blood counts or other immune system problems. Next medication I'll talk about is hydroxychloroquine, which is also known as Plaquenil. So this is a pill that's taken by mouth. Yeah, sorry.
I don't know how true it is, but I heard long-term use of methotrexate can cause sterility. Is that true?
That's not something that I've heard in my experience. It is contraindicated in pregnancy, but it's more because of the effects it can cause in pregnancy.
We recently switched from the methotrexate shot to the pill. Can that affect the LDH in the blood test at all? Or would there be a different reason for his liver enzymes to be elevated?
So one thing about liver enzymes in general is AST and ALT, which you heard about from Dr. Huber, can also be muscle enzymes, so it can be sometimes complicated to differentiate out. You often need to use some other tests that are more specific to liver, like GGT or bilirubin, to differentiate what's really coming from the liver versus from the muscle. For specifically switching from injection to oral, that wouldn't necessarily cause more side effects in the liver, but it's a case-by-case basis, I guess. And Dr. Huber can add.
There are, excuse me, there are a couple of reasons why that may be. One is that there are lots and lots of kids with methotrexate for years, and all of a sudden, 1 month or 1 year, they all of a sudden have significant elevations that are methotrexate related, but why exactly that happened then and another time is a bit unclear. The one difference between taking methotrexate as a pill and taking it as an injection is that when your body absorbs methotrexate from the gut, the first place it goes is directly to the liver, as opposed to when you give it as an injection, where it ends up in the bloodstream, gets diluted, and ends up in the liver eventually. So theoretically, there's a possible reason why you might tolerate it less well as a pill. I can't say that we've seen that consistently, and really we have thousands and thousands of kids with arthritis on methotrexate, and there's never been any sort of consistent explanation that one is more risky or less risky for the liver than another. But that certainly may be, it's possible that that could be influencing it.
Mm-hmm. I have two questions. The first one, when you talk about the vaccine regarding the kids still on the methotrexate, my daughter have not finished all the vaccine, the required one, the standard one. So, but she's on this medicine. So, in your opinion, should we continue get the vaccine or just not doing it?
We do recommend still getting vaccines because in general they help provide protection against those infections. And as I mentioned, most vaccines are not live vaccines. The most common vaccines that are in the schedule that are live vaccines are MMR or measles, mumps, and rubella, and varicella. And those are usually at like 1-year-old and 4-year-old.
18 months old.
And there is one that I mentioned, flu vaccine. The nasal flu vaccine is live, but you can get the injection flu vaccine, which we do recommend every year, and that's a killed flu vaccine, so that's okay.
So, in your opinion, as long as the vaccine is not light vaccine, that should be okay.
Yes.
My second question is, in this medicine, there's two forms. One is taken by the pill, and other one is by the needle. Which one is showing much the body take most effect?
So in general, injection or IV medications are better and more easily absorbed by the body. And actually for myositis in general, we know that the blood vessels are very involved and there's inflammation in the blood vessels. And there's even been some studies to show that in myositis, they don't absorb as well. So IV steroids, for example, are probably better than oral steroids. And that's probably something that carries with some of the other medications as well. So actually for methotrexate in myositis, the injection form is the preferred method if possible.
Okay, thank you.
So hydroxychloroquine, it's a pill, it's taken by mouth, it's used tablet, and it can also be available in liquid form, but it has to be compounded in a specialty pharmacy. In general, it's an adjunct and not necessarily the primary therapy in myositis, and particularly it's been shown to help with skin disease. Hydroxychloroquine was initially developed as a treatment for malaria, and it has many mechanisms of action, but one way it works is to block certain receptors that have to do with the immune system inside the cells that are called toll-like receptors. So this is showing that it blocks these toll-like receptors or TLR receptors inside the cell. So again, the most common side effect that's seen are GI or gastrointestinal types of symptoms. You can get gas, diarrhea, nausea, and vomiting. Some people may get certain skin changes, like you can get darkening in areas called hyperpigmentation or different types of rashes. But overall, these are not considered very dangerous side effects. And they might be reversible with dose reduction, but sometimes even if you just stay on the medication, they can go away on their own. Anemia is something that can also be seen with hydroxychloroquine or Plaquenil, but it's particularly seen if someone already has this other condition, glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency. Another thing that you probably hear about if you're on Plaquenil is that you need to get your eyes checked because you can develop an eye toxicity with chronic use. You can develop deposits, particularly in the back of the eye called the retina, which rarely, particularly with higher doses and over a long period of time, can cause vision loss. So it is recommended to have your eyes checked by an ophthalmologist, particularly a retina specialist, right when you start or before starting the medication, and then on a regular basis. But this vision loss has most predominantly been seen in adults that have been on higher doses than we typically use and for a very long time. Next medication I'll talk about is intravenous immunoglobulin. So this is only IV, like the name says. And like we've heard some about is immunoglobulin or antibody is produced by B cells. So they go into the bloodstream and you have many different types of antibodies in your bloodstream. And how it's collected to be given as a treatment is it's pooled from many blood donations and they screen it for infections and then they screen specifically for this immunoglobulin or antibody. And it's given IV in various regimens. It's probably more frequently given when someone is quite sick or in the beginning of treatment. And then spaced out sometimes to monthly, or it can be tailored to your child's symptoms. Most common side effects that we hear about, particularly when it's at high dose, and we use pretty high doses usually, or the rapid infusion, are headache, nausea, and vomiting. And there can also be a kind of a flu-like or infusion-type reaction with fever and chills, diarrhea, achiness, rash, and itching. In general, these symptoms may occur right around the time of infusion up to the day or two after the infusion. In general, these side effects may go away on their own within about a week of the infusion. Things that we recommend to try and avoid these side effects, or at least improve them, are to make sure someone is well hydrated. So coming well hydrated when you come for the infusion, and sometimes adding more IV fluids to the regimen of the IVIG can help, and slowing the rate of infusion. And generally, it takes several hours to receive an IVIG treatment. So for some people, it can be given within a daytime only center, or for some people, it may require being separated into 2 days or staying overnight. Lowering the glucose content in IVIG or lower osmolality, or like the thickness or the kind of syrupiness of the solution may help, which is not necessarily something people can choose because their hospital or center may only have one brand. And also, it's often given with different medications prior to the IVIG or pre-medications like acetaminophen or Tylenol, diphenhydramine or Benadryl, and steroids. So sometimes it is coordinated with IV steroid doses that you're getting for your treatment as well. One thing that can also be seen with IVIG is a breakdown of red blood cells or anemia. And this type of anemia is caused by something called hemolysis. And rarely, and mostly in adults, there is an increased risk for blood clots and problems in the kidneys, but that's more with certain brands or types of IVIG. And again, for these things, we recommend being hydrated well, trying to avoid certain types of IVIG that include sucrose, monitoring laboratory studies for the anemia and the kidney function, and regarding blood clots, if possible, to avoid estrogen products such like in birth, for example, in birth control pills, because that's known to be associated with increased clotting. A very rare side effect that can be seen is anaphylaxis, which is a severe allergic reaction, which is why they usually monitor your blood pressure closely while you're receiving an infusion. And it is more common if you are known to be IgA deficient, which is a particular type of antibody, so it's usually checked before you get your first infusion. Monitoring blood pressure closely, having emergency medicines for that type of reaction while you're getting the infusion available. With IVIG, it can affect the way you respond to vaccines. It's not something that you'll feel or cause any immediate problems, but normally after you receive a vaccine, your immune system learns how to react to that vaccine. But since you're receiving this high dose of immunoglobulin, your body may not get exposed to that vaccine in the same way, so it may not learn that response. So just to be aware that you may, even if you get, it's okay to get vaccines during that time, but you may need to get vaccinated again to get the response afterwards. And if it's possible, to try and complete vaccines prior to starting. Next medicine we'll talk about, we don't have much time left, but it's mycophenolate mofetil, or MMF, or Cellcept. This is an oral medication. It can also be available as an oral solution, but again, it usually has to be done in a special compounding pharmacy. There is one version that's called Myfortic that's enteric coated, which has the same core medication, but the dosing is a little bit different, just in case you hear about different versions, and they're not interchangeable because the dosing is different. This also works in a DNA synthesis pathway, but it is more specific to immune cells, and it blocks this particular enzyme at this site, inosine monophosphate dehydrogenase. So the side effects that you see with mycophenolate or Cellcept are upset stomach, nausea, vomiting, and diarrhea. Less commonly, you may also see these other things: headache, dizziness, difficulty sleeping, tremor, and rash. And often with this medication, the doses started low and then tapered up slowly, because that's been known to help with some of these side effects. And it's usually given up to twice a day or 4 times a day with the same total day dose. But giving it more frequently in smaller doses may help with some of the side effects if that's possible. And some of these side effects will go away with time. Low blood cell counts can be seen with mycophenolate. So we monitor blood lab tests closely, and we know that these are reversible if the medication is stopped. And then again, since we know that this affects the immune system, there's a decreased ability to fight infections, so that some of the same general precautions are recommended. And this is another medication that we know can be dangerous during pregnancy. It causes birth defects, so it shouldn't be given during pregnancy. So there are other medications that we can talk about, but I think we're out of time. In general, as a field, we would like to work towards minimizing side effects and work towards more personalized medicine. And some of the research that I happen to be doing with the Cure JM grant is looking for biomarkers and gene expression and protein expression to better identify things that are more specific to myositis and even more specific to specific antibody groups to help with monitoring and finding medicines that are better for certain individuals. So we're happy to take more questions.
So my question is about steroids. My daughter has been sick for 5 years, so she's been on steroids this whole duration. Sometimes it's twice a week, monthly with infusions. But she has a normal thyroid panel. She also has normal liver enzymes. Her hemoglobin AC1 is also normal, but she has no sign of diabetes. However, her insulin level is extremely high, and she has developed insulin resistance, increased weight gain, and acanthosis. Yes. So I don't understand, how does she get all this, but everything else is normal?
Well, oftentimes because steroids, it is something, it's basically just like something that works in your body to help with your glucose management. So sometimes you can have some features that look like what people traditionally think of as diabetes, like that darkening of the skin and insulin levels being high without some of the other features like the hemoglobin A1C, like you mentioned. So you may have some features without other features. And that's because of the steroid acting like something that's normally in your body. So it's not going to fit all the features of a disease necessarily.
So she looks like she has diabetes, but she doesn't, basically.
Probably, and it probably doesn't necessarily matter what you name it. We probably just have to manage those symptoms of having high insulin, which we know is related and can be seen with the steroids.
Okay, so my other question is, they are wanting to start metformin, but they don't want to start metformin because of the side effects. Because it's like she does it, but she doesn't. But then they think it can help her, but then they're worried about the side effects. So I just don't know what to do.
I don't think that there's a clear answer about the use of metformin from our perspective. It's probably a case-by-case basis based on your family discussing with your rheumatologist and an endocrinologist.
Okay. Thank you.
As may have come up in discussions, right, diabetes kind of exists in sort of two flavors. There's the typical one that young children tend to develop where their pancreas stops making insulin. And there's the type which most adults develop called type 2 diabetes where people develop insulin resistance. And so they basically don't respond to insulin the way they're supposed to, which is basically one of the effects of prednisone. So being on steroids makes you insulin resistant. It sounds like your daughter, I suspect that she probably falls into like a pre-diabetic kind of category. But if she doesn't have problems with her blood sugar, I assume you guys have seen an endocrinologist. Yeah. It's, I guess
they're saying that it's extremely high, not just high, it's extremely high, but she doesn't have, by textbook, she doesn't have diabetes, but she has extremely high insulin levels and the deposition of the darkening of the skin.
I think probably the most important question for you to go back with is, well, what's the goal of using something like metformin? Really, if the goal is to reduce her insulin level, that's not necessarily going to be a goal that's particularly relevant. If the goal is to prevent her from developing full-blown diabetes, that's a different goal. And I think that probably is the more important question, is not chasing a blood test, but actually doing something because there's a purpose to it.
I guess what they're also fearful of is because she's already developed these side effects because of steroids, and then they start on another one, she's going to get more side effects. So it's like, we do or we don't.
There's definitely no answer to that one for sure. Certainly, lots of people are on metformin and they have no side effects at all.
Are they typically the same as the other drugs, the side effects?
So metformin is not a steroid, nor does it have any impact on the immune system. Well, at least not a primary effect on the immune system. It primarily impacts how cells absorb glucose, which would make me a bit concerned that if her glucose is normal, that metformin may drop her lower. Although, again, the endocrinologists have vastly more experience than a rheumatologist has with metformin.
We're at our time now. Does anybody have another question for the doctors? Otherwise, it's time for a short break, and then you can get to your next session. So,
if anybody wants to chase
you.
me down later, I'm happy to talk about any of
Awesome.
these things.
Thank you so much. This was really
We
informative.
apparently talked more than we intended.
You did great. Thank you.
I talked more than I intended.
Thank you.